Hey, it's 12 noon. We'll get started. Good afternoon, everyone, and welcome to Medical Grand Rounds. Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which we now gather. I'd like to remind everyone to please leave their questions till the end. Please enter them in the chat and please answer a brief survey that will be sent to you immediately after the presentation. This will let us know that you were present today. So finally, our speaker today comes from the Division of Nephrology, and I would like to ask our Chief of the Division of Nephrology, Dr. Rita Suri, to please introduce our speaker today.
Thank you, Nadia. Thank you for inviting the Division of Nephrology to present today. It is my great pleasure to present one of my colleagues. To introduce her today is Dr. Ratna Samanta, whom you probably all know. She's a McGill grad. She completed her master's epidemiology at Yale University and then went on to do a GN fellowship at the University of Toronto. And since her appointment to the MUHC, she has built a very strong glomerulonephritis program. She started and runs the MUHC GN Clinic, and she's also the liaison for nephrology for the Joint Rheumatology Nephrology Lupus Clinic. She is the site PI for a number of trials in GN, so our patients are able to participate in these exciting new therapies as they become available. And she's nationally recognized for her work in GN and lupus. She's actively involved in increasing patient understanding and education of glomerular disease through an effort called NephCure, which is a patient conference that was led in Montreal. And finally, she serves on the Canadian Society of Nephrology Board of Directors as a member representative of Quebec. So without further ado, I'm looking forward to her talk, compliments and insults. We're going to learn more about glomerular disease today. Thank you, Ratna, for presenting.
Thank you very much, Dr. Suri and Dr. Giannetti, for the introduction. And I wanted to thank the Internal Medicine Committee for inviting me to speak today. So we'll be talking about glomerular diseases and some of the objectives, sorry, it's not moving. There you go. Some of the objectives for today is to review the approach to glomerular diseases. I wanted to introduce the complement cascade and really understand some of the implications in glomerular diseases. These are some of my disclosures. So, excuse me, glomerulonephritis literally translates from inflammation of the glomerulus. The true incidence of glomerular diseases is relatively unknown because unfortunately we don't always know the onset of glomerular diseases. And while each particular type of glomerular disease is relatively rare, collectively they account for 20% of end-stage kidney disease in Canada. The symptoms of glomerular diseases has been described as far back as 460 BC by Hippocrates, and he actually used the term nephritis to describe hematuria and oliguria. And he was actually one of the first ones to notice that frothy, bubbly urine, which we now know actually is a sign of proteinuria, was very highly suggestive of chronic kidney disease. So I just wanted to start with a very brief overview of anatomy for a better understanding of glomerular diseases. So ideally, we all have two kidneys, and each kidney has millions of filtering units called nephrons, which in turn can be broken down, as you can see over here, to the glomerulus, the tubules, and the collecting ducts. Blood comes in through this afferent arteriole, filters through the glomerulus and the Bowman's capsule, and that filtrate that filters through gets refined by further secretion and concentration in these tubules and the collecting ducts to finally make the urine that we release into the bladder. But if we take a closer look at the glomerulus, we see that it's really just a ball of capillaries, a link between this afferent and this efferent arteriole. And if you look in the cross-section over here, all these capillaries are held together by a stack of cells called the mesangium, the purple things, which I'll refer to in the future. These capillaries are lined on the inside by the endothelium, and on the outside, they're lined by these special epithelial cells called podocytes. These layers ensure that proteins, what we call larger and middle-sized molecules in the blood, are not just simply urinated out. There's a negative charge actually associated with each of these three layers, and it's thought to prevent filtration of anionic molecules, so negatively charged molecules such as albumin. The podocytes on the outside are what are the main size barrier to proteins. During glomerular injury, depending on whether the primary injury occurs on the inside, we can see nephritic syndrome, and we see hematuria, AKI, and hypertension, or we might actually see nephrotic syndrome, where the injury occurs on the outside of the epithelium and the podocytes, leading to proteinuria, hypoalbuminemia, and edema. So we can make relatively educated guesses based on what we expect on biopsy. For example, a nephrotic syndrome here on the left is more likely to yield these diagnoses over here in comparison to a nephritic syndrome here on the right, which is more likely to yield these types of conditions. But while we can make these educated guesses, we really need a kidney biopsy to assess the type of injury that's occurring at the histological level. You may notice the nomenclature for a lot of these different GNs is actually taken directly from the histological description. For example, minimal change is named because there's literally no changes or very minimal changes that we see on histology. In comparison, something like IgA nephropathy over here is named for the very strong IgA staining that we see on immunofluorescence. And post-immune GN, also known as ANCA-induced associated vasculitis, has almost no staining, almost POSI staining. But we don't just look at the presence and the absence of immunoglobulins. As you can see on this table, we actually look at the different patterns that they make, along with some other components, including complement components such as C3 or C1q to aid with the specific diagnosis. Excuse me. And up until recently, many of our therapies for different types of glomerular diseases were non-specifically targeted at reducing inflammation, either locally at the kidneys, such as glucocorticoids, with other therapies that actually targeted adaptive immunity in the lymphoid organs, such as antimetabolites, cytotoxic agents such as cyclophosphamide, and even other therapeutics that affect B and T cell formation and maturation. For the past decade, really the only exception to this rule were calcineurin inhibitors, which acted directly at the site of glomerular injury. But there's more data emerging that the glomerulus with those three layers is not just a simple anatomic barrier. It's actually recognized as a site for signaling pathways, and as well as immunological diseases of the glomeruli, including the complement system. So what the heck is the complement system? So it's a system of plasma proteins that have a central role in host defense against many microorganisms. And it's literally named on the basis that it complements the activity of antibody in the lysis of bacteria and protecting the host. So there are three different pathways of the complement system. You have the classical pathway, the lectin pathway, and the alternative pathway. Again, this system is meant to aid in the function of our humoral system in host defense against pathogen. The clinical pathway is initiated by an antibody, usually complex to an antigen, presumably from a foreign pathogen, and then actually cascades down this communal pathway all the way down to this terminal complex, which leads to cell lysis and activation. The lectin pathway, right here in the middle, is initiated when receptors bind to certain patterns of sugar groups that are often present on bacterial cell walls, and again goes down the communal pathway down to cell lysis. The alternative pathway is a little bit different. It's constitutively turned on and turned off, something what we call the tick-over process. I tend to think of it as like a room where the light is constantly turning on and off, and only actually remains on when a pathogen is identified when the light is on. So the complement system must respond adequately to pathogens for appropriate host defense, but this activation must be controlled to prevent unregulated and constant activation. This balance of activation and deactivation is maintained by a group of complement regulatory proteins, which you can see here are sort of marked in this brownish orange. These regulatory proteins are extremely important in ensuring proper activation of the complement cascade, as when these regulatory proteins are impaired, either by congenital deficiencies, such as a mutation impairing the ability to function properly, or an acquired deficiency, such as an antibody that targets the protein, again, impairing it from functioning properly, it can cause uncontrolled complement activation on host cells, which in turn leads to inflammation and damage. Complement proteins actually have been seen in kidney biopsy specimens, as I alluded to earlier, from patients with virtually all forms of glomerulonephritis, and complement pathways have been linked in various types of kidney diseases. Although complement activation occurs downstream of immune complex deposition or antibody-mediated injury in many of these diseases, we actually see complement activation in kidney diseases that are not antibody-mediated. This wide variety of kidney diseases associated with complement activation suggests there's something about the structure or the function of the kidney that makes it particularly susceptible to complement-mediated injury. And while I don't think there was one pinpointing event that led to this examination of complement in glomerular and kidney diseases, atypical HUS may have been one of those windows that led insight to the phenomenon. Atypical HUS is not considered to be a type of glomerulonephritis, but its clinical presentation is quite the mimic of a glomerular disease. In general, TMAs will present with their textbook triad of microangiopathic hemolytic anemia, thrombocytopenia, and AKI from microvascular glomerular thrombosis, and can be categorized in these different entities that you can see over here. Atypical HUS, which is now termed by some as complement-mediated TMA or CMTMA, can be distinguished by the typical HUS in that it is not caused by infection, as you can see here by the table, but is usually from an aberration in the complement cascade. As the underlying issue in atypical HUS or CMTMA is an abnormally activated complement cascade, the therapy depends on the specific cause of that abnormally activated complement cascade. So factor H over here is the major fluid phase regulator of the alternative pathway of the complement cascade. And it actually targets several points within the pathway, namely at the level of the C3 convertase and the C5 convertase. These two are very interesting proteins because they're actually made of components of the split products of complement proteins higher up in the pathway, as you can see over here, the smaller gray circles within the protein. So factor H actually prevents the formation of both C3 and the C5 convertase. And if you don't have a C3 or a C5 convertase, the pathway can't move forward. And factor H also facilitates the disassembly of any already formed convertases and acts as a cofactor for that inactivation. So with the presence of a factor H antibody, the inhibiting function of the inhibitor is inhibited. It's sort of like a double negative, meaning there's literally nothing stopping that alternative pathway from just moving on forward. Therefore, high titers of a factor H antibody, the therapy is usually just plasmapheresis, just to sort of remove that antibody. But the alternative is if there is no such antibody, then maybe the therapy is just to impair the entire process completely by the use of eculizumab. Eculizumab's claim to fame came about 10 years ago when it was listed as one of the most expensive drugs in North America and actually made the Forbes list in 2012. Eculizumab inhibits the cleavage of C5, this little gray circle down here. And because you inhibit this cleavage, you do not get the C5b split product, which in turn inhibits the formation of this whole terminal MAC complex, and therefore do not get cell lysis. I will reiterate again, atypical HUS is not a form of glomerulonephritis, but it can be a secondary cause of GN. If you may remember from the beginning, I mentioned that glomerular diseases are really just named after histological patterns. MPGN, or membranoproliferative glomerulonephritis, is what we call a pattern of injury when the glomerular basement membrane just splits in two. And as you can see, there's various different diseases that can cause that initial MPGN pattern, and we really just differentiate them based on immunofluorescence. C3GN and atypical HUS is how we differentiate the two based on what we see. C3GN is one of those rarer types of glomerulonephritis, but it's actually quite serious. 50% of patients with this disease develop kidney failure in just 10 years. Similar to atypical HUS, we see that it can be caused by an aberration in alternative pathway. And as you can see, the workup of the two are kind of similar at the beginning for certain aspects, including the functional assay, the qualitative and the quantitative assays, and IF studies, but a little bit different for some of the others. Another component that actually differentiates the two diseases is where they physically occur. Typically, atypical HUS, the activation of the complement system occurs on the solid phase, meaning on the surface of the endothelium, versus C3GN, which occurs in the fluid phase, so not on the endothelium. And so you'd think, with all these similarity of C3GN and atypical HUS, that the therapies would be relatively the same, either plasmapheresis to remove some autoantibody to a regulatory protein, or something like eculizumab to sort of prevent that final formation of the N-terminal complex and prevent cell lysis damage and inflammation. Unfortunately, this doesn't really seem to be the case. Due to the significant rarity of C3GN, it's only like 1 in a million patients who tend to get it. RCTs were relatively difficult to conduct. It also didn't actually help that C3GN is a relatively newer disease, meaning it was only emerged as its own entity in 2012. But neither plasmapheresis nor eculizumab makes any significant difference in the history and prognosis of C3GN. In this small case series of 6 patients, it was noted that while C3, C5b9 albumin levels all seemed to stabilize, it didn't really make a difference in the actual eGFR slope, nor did it make a difference in proteinuria, which is a surrogate marker for inflammation and damage. And as you can see, the proteinuria actually continued to rise unchecked. So one of the reasons it's postulated that eculizumab did not work as well in C3GN, despite being a complement-mediated disease, is due to nephritic factors. As you can see, anywhere from 50 to 80% of patients with C3GN have either a C5 nephritic factor or a C3 nephritic factor. So what is a nephritic factor? So these nephritic factors, as you can see labeled over here, are autoantibodies. But rather than inhibiting anything, they actually stabilize their convertase. So the C3 nephritic factor stabilizes their C3 convertase and respective for the other nephritic factors. We spoke about factor H earlier, how it prevents the formation of the C3 and C5 convertase. It breaks them down faster and prevents the pathway from moving forward. The nephritic factors do the exact opposite effect. They increase the stability, they increase the half-life, and as such, the alternative pathway continues to race forward, leading to that cell lysis, damage, and inflammation. But then the very valid question is, who cares? Because you have eculizumab, you could still potentially just impair C5 right here from forming that terminal MAC complex anyways. But the answer might be in the fact that it's not just the MAC complex that leads to damage and inflammation, and split products that are produced higher up in the pathway may not necessarily be benign themselves. So it's actually been demonstrated in various studies that both C3A as well as C5A, which are split products from C3 and C5, respectively, can cause damage and inflammation independent of other components. C5A is a much more potent anaphylatoxin in compared to C3A, but their effects have not just been demonstrated in kidney diseases. C5A actually has been found to be elevated in the serum of patients suffering from multiple inflammatory disorders, and it's been shown to be significant in the onset and progression of diseases such as rheumatoid arthritis, IBD, Crohn's, bullous pemphigoid, COPD, atherosclerosis, and etc. So maybe this was the root cause of why eculizumab did not work in C3GN. And so until 2018, the only therapy that really showed any improvement in C3GN was a combination of MMF and steroids. But as you can see, less than 70% of patients ever achieved some type of response, not necessarily complete remission. And even then, there were really only 30 patients in that study. But thankfully, there have been some updates in the past 7 years. as you can see from another rendition of the complement cascade, there's been significant work in identifying regulating factors and upstream complement products within the complement cascade. These red stars over here actually point out targets for therapeutics. And in the past 2 years, 2 of these targets have borne fruit. In phase 3 studies, APL2, or also known as pegcetacoplan, which targets C3 directly, so over here, and as well in the middle of the screen, has been shown to reduce proteinuria in patients with C3GN by 68% in the first 6 months, and LNP026, also known as iptacopan, which binds factor B over here, reduced proteinuria by 45% in the first 12 months. We don't really have any long-term data. Literally, all this evidence came out less than 6 months ago. But proteinuria reduction is generally a marker for good outcomes in kidney disease. But we still actually need to know whether any of these therapies actually affect the slope of eGFR, meaning, would it mean a reduction in the progression to end-stage kidney disease? And as I said, both of these studies have only come out in the past 6 months, so neither is approved for C3GN yet. Interestingly, though, iptacopan, that I just mentioned, is already approved for a completely different glomerular disease, IgA nephropathy. So what is IgA nephropathy? So it's actually probably the most prevalent primary GN worldwide. Its prevalence rate is likely underestimated because many patients present only with microscopic hematuria. Many never progress any progression to end-stage kidney disease or chronic kidney disease, and they never have a biopsy to confirm that diagnosis because they're so asymptomatic. And because of this, because they may be so asymptomatic, they may even never present to a physician in the first place if urine tests are never done. Again, the kidney biopsy reveals the histological pattern after we name the diagnosis. So IgA nephropathy is really termed to illustrate the predominance of IgA deposits, either alone or with IgG, IgM, or C3 in this glomerular mesangium, those cells that hold the capillaries together. And this is sort of illustrated nicely where you see these nice bright green immunofluorescence and compared to the relatively negative immunofluorescence, remember this is negative, around it. So the moniker IgA nephropathy would insinuate that there's an abundance of IgA antibodies that overflow and deposit into the mesangium. But this actually isn't the case. Most patients with IgA nephropathy actually probably have normal immunoglobulin levels. But then why would they have so much deposition in the mesangium? The reason for this may be due to an issue with the structure of the IgA antibody itself. So we all have 2 subclasses of IgA. We have IgA1 and IgA2. And in IgA, we actually have in the hinge region, we have these O-glycans. And there's an analysis of patients with IgA nephropathy that suggests that these patients have an aberrantly glycosylated IgA1. Because it's so differently glycosylated, it leads to a kink in this structure of IgA. Because of this kink and this abnormal formation, there are autoantibodies that are formed towards this aberrant IgA1. They form immune complexes in the bloodstream, and then as they filter in through the kidneys, they deposit in the mesangium and cause that nephritogenic response. With the elucidation of the pathophysiology of IgA nephropathy, there's been actually multiple targets along this pathway that's been identified. But let's just talk about targeting the complement cascade for this condition and how that seemingly treats this disease. So the clinical presentation for IgA nephropathy is very variable. As I mentioned earlier, many patients have asymptomatic microscopic hematuria, but it ranges all the way from that to an RPGN. A very small proportion of patients will have nephrotic syndrome and even a smaller proportion with a TMA. But as you can see, there's a significant clinical difference in renal outcomes in terms of patients with IgA nephropathy depending on their initial presentation. The lower the eGFR presentation and the higher the proteinuria presentation, the poorer their renal survival. But then why do some patients with IgA nephropathy present so differently? there's a theory that complement actually has something to do with this. And it was actually noted in several different studies. The presence and degree of C3 immunofluorescence on that kidney biopsy is also correlated with poor renal outcomes. The stronger and brighter it is, the poorer the prognosis. And so with that, several molecules outlined here in these blue circles over here are being tested in IgA nephropathy. But the first one to come with positive data is that LNP023, or that iptacopan. So iptacopan is a proximal complement inhibitor that specifically binds to factor B over here. And this is factor B is a positive regulator of the pathway and is actually a component, an important component of both the C3 convertase as well as the C5 convertase, again, which pushes the pathway all the way forward. If you inhibit factor B, you inhibit activity of the C3 convertase, and you actually inhibit formation of the C5 convertase. Therefore, you're preventing downstream cell destruction, excessive complement deposition, and whatnot. But interestingly, if you think about it, you're actually also preventing formation of those C3A and C5A, those anaphylatoxins that I was just mentioning earlier. The phase 3 APPLAUSE study tested patients treated with iptacopan in conjunction to standard of care therapy and actually have demonstrated improvement in proteinuria by anywhere from 35 to 38% in the first 9 months. And in nephrology, many of our outcomes are tied to reduction in proteinuria. So this is kind of happy data indeed. These positive results seem to have led to the early approval of iptacopan for IgA nephropathy, but we're still just waiting to see whether it actually affects eGFR slope, again, which slows the patient's descent into end-stage kidney disease. The last glomerular entity that I will be discussing is ANCA-associated vasculitis. So small vessel vasculitides encompass a group of diseases characterized by necrotizing inflammation of small vessels and can be characterized as either immune complex or ANCA-associated. Both have a circulating antibody, but in immune complex, there is a large burden of antibody that precipitates down, deposits, causes inflammation, versus in comparison, ANCA-associated vasculitis, there is little to no deposition of those immune complexes in the vessel wall, and so it leads to that post-immune picture that we see on IF. The pathogenesis of ANCA-associated vasculitis is not completely elucidated. There are unclear mechanisms over here that prime neutrophils, which are then theorized to be activated by an ANCA antibody. And I'm saying theorized because 10% of patients with ANCA-associated vasculitis are actually ANCA negative. So it might be some other antibody that's causing the activation. But in any case, once these neutrophils are activated, they bind to the vascular endothelial wall, cause inflammation. This inflammation leads to a cascade of other effects, leading to a positive feedback loop. But interestingly, it was actually found that the alternative complement pathway was one of these activated pathways. And the final product, C5A over here, further primed neutrophils. And so that path sort of continues again. But what if you stopped this positive feedback loop? So mouse models actually noted the involvement of the complement cascade in ANCA-associated vasculitis, and human studies have demonstrated there are also elevated levels of the terminal MAC complex and several of the split products in patients with active ANCA vasculitis. Specifically, if you see C3A and C5A were even higher than active lupus. But interestingly, when these patients were in remission, these levels were much, much lower. There was this very small study of 46 patients that noted that patients with ANCA-associated vasculitis, those with lower C3 at presentation, had a poor prognosis in terms of renal and overall survival. Fortunately, this study has never been reproduced, and we don't really use it clinically, but it is interesting. There have been more studies in animal models that were conducted, and it was noted that transferring an MPO-IgG, so an ANCA antibody, into mice caused a crescentic GN, which if you blocked the complement cascade by depletion, actually reduced this crescentic formation. These investigators administered a molecule called CCX168, which is an orally active small molecule designed to be an antagonist of the C5A receptor and was found to reduce the severity of MPO-induced necrotizing crescentic GN in just 7 days. This was in mice, not in people, as well as more clinical symptoms of hematuria and proteinuria. So if we look back at that positive feedback loop, the molecule that was being administered was a C5a receptor antagonist inhibitor right here in the middle. And so true enough, it seemed that inhibiting the C5a from interacting from this receptor seemed to stop this loop completely in mouse models. But of course, we have to assess this in humans. So this molecule was termed avacopan, and it was assessed in this randomized controlled trial where patients with ANCA-associated vasculitis were randomized in a 1-to-1 ratio to receive either avacopan or against placebo or with steroids at a tapering schedule. This was on baseline standard of care therapy with either cyclophosphamide or rituximab. One of the really interesting things about this trial was the aim was to see whether avacopan could actually replace a glucocorticoid tapering regimen that's typically used in ANCA-associated vasculitis. So as you can see, the patients in the avacopan group were not supposed to get any steroids whatsoever. But, what seems to work in theory may not always work in the real world. And of course, clinicians are very uncomfortable not giving any sort of steroid for patients with ANCA vasculitis. So 80% of the clinicians actually still gave steroid. But anyone who received steroids and was still on 20 milligrams of prednisone on day 1 were tapered to 0 by the end of week 4. But as you can see, avacopan was non-inferior, but not superior to tapered prednisone in terms of remission, but was superior in terms of prednisone in terms of sustained remission, as well as relapse. So avacopan was actually approved by the FDA in 2021 as an adjunct therapy for patients with ANCA-associated vasculitis. So as you can see, while avacopan has been already approved, there are multiple other targets that are being assessed now for use in ANCA-associated vasculitis at this point. So hopefully we'll hear more things in the future. And so we know right now there's a clear but not completely defined role for the complement cascade in various forms of glomerulonephritis. And there's been lots of strides in knowledge for therapies leading to conditions that have risk for morbidity and mortality. And we actually have 2 FDA-approved drugs in the past 4 years, and hopefully a few more around the corner. I wanted to end this talk taking a page from my colleague's book, Dr. Bernd Ianakowski. He gave a talk a few months ago on calcium regulation in the kidney, and he ended it with a poem that he generated with ChatGPT. So I sort of did the same. I'll let all of you read it at your discretion, and I'll take any questions if there are any. Thank you for your attention.
Looking at that poem, thanks for sharing that with us. I will take questions. Are there any questions in the audience? I have a few nephrologists here, or any questions in the chat. There's a question in the chat from Dr. Doss about the IgA nephropathy following viral URI, including but not only SARS-S2 and COVID mRNA vaccine, due to excess IgA production, or is it due to excess IgA production or due to glomerular leak, and how lasting are these?
So that's a really interesting question. I mean, I think all of us during COVID had reemergence of different conditions that sort of popped up. There's a thought that with IgA nephropathy, one of the reasons why, sometimes you did see a resurgence of glomerular diseases or flares with a COVID either infection or vaccine was because when you had particularly with a vaccine, when you were creating more antibodies, then if the person was already predisposed to make this aberrant kinked IgA, then they were actually producing more of this aberrant IgA, so which may have led to resurgence of either new diseases, like new IgA presentations or flares of these conditions. Usually, I don't. The natural history of how long these would last weren't any really different from other IgAs that were sort of not COVID related.
Okay, Dr. Pilote wants to know if we have access to these novel therapies at the MUHC.
So, Avacopan, yes, for ANCA vasculitis. We have had access to this for, I want to say, the past year and a half. We've had them. The other complement inhibitors technically are not available in Canada. However, through applications to Health Canada, I've been able to get access to them. So it is a little bit more paperwork at this time, but it is doable. And of course, we have them on trial basis when in clinical trials. We were actually McGill was involved in the iptacopan study for IgA just a year ago or two.
Now, practically speaking, who would you like us to, who are the appropriate patients for us to refer to you, and how would we do that?
Oh, I mean, I think if for anyone who has a glomerular disease with defined biopsy findings of these patients, unfortunately for IgA nephropathy or a lot of these other conditions, if steroids does tend to be one of our first line therapies, but as you know, steroids have many side effects and long-term side effects. And we are not just in nephrology, I think, in every medical subspecialty, we're trying to go towards more targeted therapy. So for these patients, anyone who has a biopsy defined disease, who is not well controlled on conservative therapy alone. So conservative therapy, including, blood pressure control if they're on RAS blockade, SGLT2s, whatnot, and are showing signs of clinical decline with drop in EGFR if it consists or have persistent proteinuria greater than 1 gram. These would all be patients who would be definitely accepted and screened for a study. Or if you're just not sure and want them or if they're just not doing well on therapies.
A question from Patricia Tonin. Is there any evidence that hereditary genetic variants play a role in IgA nephropathy?
So far, I mean, I'm not aware of any at this point in time, but I wouldn't be surprised if there was. Because again, we don't really understand why some people present. There's such a broad variation in clinical phenotype in IgA nephropathy. So I wouldn't be surprised if there definitely was.
Dr. Gilfix is telling us that most of the necessary testing is not done in Canada, but sent to University of Iowa.
I absolutely agree with that. That's exactly who I send all my testing to. The physician in Iowa, Dr. Richard Smith, is fantastic, and actually sends really nice reports in terms of all his complement testing and the interpretations of what they're seeing, and he's very open to discussion on phone. So I'm a very big fan of Iowa, indeed.
Fantastic. I'm assuming that Brian is trying to tell us it's not inexpensive. Is that also one of the comments you're trying to make there, Brian? You can unmute Brian if you want. Okay, no comment about that. Any other questions? I don't see any other questions in the chat. Are there any other questions in the room? Just one last thing. Any other organs involved that will respond the same way? Oh, very expensive. There you go. That's what I suspected.
Yeah, I was actually getting excited when it might be cheaper.
Yes, no, okay, we got the very expensive. Okay. Organs that would respond similarly.
So I wouldn't be surprised. I'll be honest. So for example, for ANCA vasculitis, when they looked at patients, not all patients actually necessarily had renal involvement. Quite a large majority didn't even have kidney biopsies because they had other manifestations of ANCA vasculitis. And they did actually, and there were some posters actually at our very recent nephrology conference suggesting that it did improve other organ systems presentations in ANCA vasculitis, such as like ENT, lung, and whatnot. In those studies as well, in the ANCA vasculitis study, exclusion criteria were also of, diffuse alveolar hemorrhage and whatnot. But in the real world, they actually did seem to, there were small case reports of, a couple of patients here or there, but they also seem to improve. So, our complement cascade is systemic. Would do these things help in other organs? Absolutely. While I was doing some of the research for this talk and trying to pull up nice imaging, there were actually some beautiful images rendition for complement cascade causing issues in the lung, causing issues in the GI tract. But other than those broad terms, I can't be more specific. But yes, they are definitely involved in other organ systems as well.
Fantastic. Well, if there's no other questions, we'll stop there. Thank you. Excellent presentation. Really, really amazing topic that we don't get to hear about often. So thank you for sharing that with us. I wish we have a few extra minutes today, so I'd like to wish everyone a great afternoon and thanks for joining us. And see you next week. Bye-bye. Thank you.
Very much.
Bye.
Bye.